A row, a ruction, a fracas and a fray, a rough and tumble free for all, a broiler brawl a Malay, a ruckus to be reckoned with if anyone wants to dare. We're taking the road to the Don or on down to the Donnybrook Affair. I will go, I will meet you there, I will spend a week or two with you in Donnybrook Fair.
Hello, everyone. Welcome to part one of our head and neck results podcast. A special thank you to all of our participants, our panelists, and to those that have joined us live here today. For those of you who have not done so already, whether you're attending live here today or if you're watching this on our channel, we would like to direct your attention to a brief survey in which you can let us know what you most benefit from as a part of C3RO and what you'd like to see more of in the future. I'll share that link in the chat box and in the comments below. Stay tuned later on for some gift card giveaways and information regarding part 2 of our head and neck case. And should you have any additional questions or feedback, please feel free to send us an email at support@econtour.org. Thank you all for your attention.
I'm Musa Wan, Musaddiq Wan, Moose for short. I'm a radiation oncologist who primarily does head and neck and skin cancers at the Medical College of Wisconsin.
Hello, my name is John Caticedo. I work at Cruces University Hospital in the Basque Country, north of Spain, and it's a pleasure to be here today with you.
I'm Dave Fuller. I'm a head and neck radiation oncologist at MD Anderson. Happy to be here. So I guess the question that really had me going is, on your exam, how much soft palate involvement did you see?
Yeah, exactly. When I wanted to start this delineation, the general tendency is to see just radiological images, but it's pretty important, as you all know, to look carefully for the superficial extension of the disease, especially in this case, affecting the soft palate in the right side. So in the general examination, you could easily see some kind of red infiltration in the superficial mucosa, not reaching really the midline, but clearly affecting the soft palate.
So kind of like lateral third, or would you say it crossed over to, I mean, within a cm of the uvula? How would you describe?
Yeah, I would say lateral third, not reaching midline.
Okay.
I would describe it, summarize something like that.
The question to me was, once you get up into this artifact on the CT, it was fairly hard to kind of see soft palate,
exactly,
juncture and extension. And looking at the fused PET, right, you could see that there was uptake there, also kind of volume averagey levels, right? So again, not hard or discrete. And I think, like John's saying, I'd emphasize that this is where the kind of clinical exam comes into your segmentation, pretty hardcore, right? If you look at this GTVP, I struggled once we got into this artifact here to kind of articulate how much of the soft palate exposure, was there radiographically, right? So I think if you go back to what, I think similar slice here, I'm kind of in between John and Moose on that superior coverage.
Yep. I think probably the one of the reasons for the small discrepancy here is that we didn't all see the same information, really. So I personally saw, let's say the soft palate and how it was infiltrated, and you make up in your mind an idea. You try to translate it anatomically to the region at the CT, and you to have moreover the information of the radiological image. So probably that's also a source of discrepancy for that.
You can see I didn't cross midline, so that's kind of where I stopped it, based upon the description. And so
exactly. Yeah, what I think, just one comment, is that we all tend to do very similarly in these slices where there's kind of clear gross disease radiologically, and we have, the cranial limit is where we find the discrepancy, probably due to the artifact and because we are just based on the physical examination description. So that's probably the reason for the last 3-4 slices that are pretty different, or compared to the rest of the volume that it's pretty tight in general.
And I feel like, if you look at this level here, as we're coming up here, I felt like, visually what to do at these 2 slices right above the maxillary tuberosity.
Yeah.
I had a hard time tagging that, right? I had a hard time tagging it on the PET. I had a hard time kind of tagging it on the CT, right? So I don't think it'd be wrong, because I think Moose's slice is right about here.
Yeah.
And I could certainly talk myself into covering that as GTV.
Yeah.
So I think, on the CT, pretty solid agreement.
Mm-hmm.
I don't know. I'm curious, for us, what that buys when we talk about the CTV2 and the CTV1 is there's this kind of amorphous threshold somewhere between 1/3 and 1/2 of the soft palate, where we convert to elective coverage of the entirety of the soft palate, right?
Mm-hmm.
So for us, if it comes to the uvula, now you've bought contralateral. But for us, if it really is kind of, within a centimeter and a half of the uvula, we kind of take the jump and move to that soft palate coverage with elective dose, right? So I'm curious to see when we get to that, how that modified that for you guys. John, the other thing I was real curious about is, if you're coming down here at this level, again, a lot of artifact in this juncture, but, I felt like as I was looking at it, it looked like it didn't cross over the glossopharyngeal sulcus, but it looked like it was, kind of space filling there. But then as you got down to this follicular region, the PET seemed indicative of a little bit of run down on the vallecula with phonation. Did you appreciate that there as well?
Regarding the caudal limit, truly the physical examination was somehow difficult to appreciate clearly what was the bottom line of the tumor. So I based mostly in that small uptake at the caudal limit of the image. So that's why I made a very small slide, also caudally. But there was not clear invasion of the vallecula at all in the physical examination.
So not there wasn't any, you couldn't really palpate or see anything on the surface properly. Okay.
No, not really.
Yeah, I thought that was kind of the edge of maybe the tonsil kind of sitting down, or kind of into the glossotonsillar sulcus. But then when I went up, you can see I didn't go into the tongue at all, based on the fact that there was no base of tongue involvement. So there's kind of a clear line for me going up on where I think the glossotonsillar sulcus border is. You can kind of see it.
Yeah.
I chased the whole sulcus just to chase any potential spread, but not really onto the tongue proper.
Yeah, and I think, I mean, again, I think this, it's always for us this question of like how much of that glossotonsillar sulcus are you going to take in terms of mandibular dose versus coverage of that potential space, right? And again, like for me, I feel like in a very similar sense to what Moose is describing, I didn't feel like you needed to come onto the base of tongue itself, but also hedging for this border of that kind of glossotonsillar, fold region there was kind of the intent. I also felt like, and this is again, that difference between imaging. Let me see if I can pull up. If you look at the window level on this, as we were kind of playing around, as I was kind of playing around with it, fairly sensitive where you find that gradient depending on how you window and level on this case, right? So I didn't see a huge amount of like a sharp, it wasn't like it wasn't like some of these contrast enhanced scans where you see really sharp enhancement of the tumor, but this edge kind of, I got a little different threshold based on how I windowed and leveled it, which is pretty common, I think, for these tonsillar tumors. I don't know. Do you guys have again, just as a thought process, do you guys use a single predefined preset window level, or do you guys kind of toggle back and forth? What's your process when you guys are coming out of that?
I toggle, so I use this, so I use a lung to define my air extent. I use usually the soft tissue primarily. Sometimes
Yeah.
I find the liver gives you a little bit of kind of better contrast in certain areas, like around the parotid and stuff. Those are primarily just lung and soft tissue though.
Yeah. We typically use, we typically will toggle back and forth between, what we routinely refer to as the abdomen preset, and then the head, and then the soft tissue one. So, it's in terms of, window level. John, is that something similar to what you guys do? Or?
Yeah, in general, I would say also I like to use first like a first general overview to make if it makes sense with the soft tissue window. But I do like to play with the window level, to see some kind of boundaries if I am right or wrong, especially if I do not have MRI like this case. Then I try to to play more a little bit with the windows just to be sure. Sometimes it helps to me.
Yeah, this one, when I pick the window level, I had I normally do this around, what I do really typically is right around 450. So so my kind of base contouring level is right around this edge, so again, you can kind of see, a little different. And then for the soft tissue, I then normally drop that to around 350, 350, 50 or 350, 60. So something closer to like that, right? So again, a little bit of difference there you can see attributable to that. So if you look right about this juncture, right, there's a little bit of uptake right at this bracket right here. Right?
Okay.
I don't know if you can see my pointer, right?
Yeah.
That I read out as a blush of RP node. There's a small discernible, it's small. It's not, it's going to be in a threshold to ride super hot, right? But this was the area of major question for me. Now, the good news is it's right above the top, of this node that's sitting right under the digastric, right? So, there was a little bit of volume averaging, but this is the guy that really caught my attention about, question about is that blush RP node coverage. I hit it as if it was, but so you can see on mine, there's going to be a little bit more posterior RP coverage based on that little blush there.
If I remember correctly, the full description of the PET-CT, it was not considered strictly as a pathologic uptake. If I remember.
But on the other hand, an RP node that size wouldn't come up pathologic unless it was blazing hot, right?
Yeah, but I understand your point. Yeah.
I think having MR is helpful for SIM, because it kind of does. The RP nodes do tend to pop a little more on MR, and again, if you look at the CT, if you look at the con CT, I also felt like as you're scrolling right up in that juncture, you can see a little bit of nodularity that made me a smidgen. You keep rolling up, Michael. Yeah, keep going, keep scrolling, and then scroll superior. Right, that nodularity here seems comparatively distinct, but not prominent, right? So, on a two dose plan, I would cover that in the high dose, but more frequently, I'd probably put like a slightly lower dose there on that small volume RP just to kind of make myself feel better, right? So for simplicity, in this plan, I kept it in the CTV1, but I think you could also, I would also probably placate my anxiety about it with that, intermediate dose as a way of kind of, hedging bets. Doesn't jump out at me, it's a hard call, but biopsying that's going to be a pain in the butt. So, and the salvage options are limited. So I would say I kind of erred on the side of aggressive coverage comparatively. Yeah,
I would have covered it electively. I mean, it's probably microscopic disease, if anything. And I mean, I think, most people treated 1 centimeter nodes in elective volumes all the time. So
yeah, it's legit. I mean, I guess I'm a little more, from a salvage perspective, Jack Fan in our group is always, now able to do these stereo salvage gamma knife procedures. And he's always telling me, hey, listen, even if you fail there, it's not the end of the world. But I'm still from that, generation where RP node failure was like a pain to salvage. And you can kind of see, consequently, if you look at if you look at the nodal coverage here, I think we agree on the big guy, right? But then coming up here, I tagged this, I tagged that within the, I tagged that based on the PET. And again, it's pretty low. It's fairly low. So this is the, coming here.
You almost wonder if it's deep low with the parotid too. I mean, it's hard to tell sometimes with
yeah, and it's, I mean, it's, again, I'm, it's something that if I had access to a radiologist, I might be able to talk myself out of. But it was enough of a blush that I felt like, if it was B, I'd cover it.
Yeah, it would be, again, interesting to see how this modifies the CTV1 in general. Once, I mean, when we expand, let's say 5 millimeters, our primary tumor on the primary node, probably dosimetrically, I mean, it would be interesting to know what the differences really are in that area. Yeah, because of the proximity already of the primary tumor to that lymph node or possible lymph node. But I do agree with you that second options sometimes of salvage. I mean, I don't really like that option either. So I pretty much understand. Second options are not always good, especially in this kind of patients. But yeah, I perfectly understand your point. Yeah.
I think our GTVs are pretty similar. Everything seems pretty similar so far.
Yeah, really, indeed, even having slightly different information. So I think that's a very important point. We haven't seen exactly the same information, but still, it's quite homogeneous, I would say. And probably from a dosimetric perspective, I don't think there would be much difference in, let's say, also again in toxicity regarding oral cavity, for example, or.
Well, let's wait till we see our CTVs.
Yeah. Okay. Yeah. Exactly. Okay. Yeah. Okay. What I generally do, I really like the HANCA guidelines, and also astro guidelines are mostly based on what I did in this clinical case, and I apply a 5 millimeter margin to the GTV, and then I try to adapt that CTV, cutting the air, cutting the bone, and especially if I also see that there are some strong anatomical barriers where there shouldn't be any, microscopical invasion, then I also correct a little bit the volume at that point. So I try to mix the, let's say, isotropic 5 millimeter margin, but also adapting it with a compartmental anatomical sense. So in that context, that's what I did, and I made a volume, adding the GTV primary, GTV node, and plus 5 millimeters, correcting it, as I mentioned, by airborne, and also again regarding some kind of anatomical aspects in this clinical case. At least that's what I tried.
Yeah. So kind of you start with that 5 mentally. It's kind of, you start with that kind of 5 by 5, the HANCA style, and then remove PTV remove
Yeah,
PTV from bone, air,
yeah,
and
every
barriers.
CTV, yeah, again, yeah, and especially mm, not maybe not this clinical case, but sometimes, for example, if you see, I don't know, for example, thyroid cartilage, and there's no need to go beyond the thyroid cartilage, and you have to correct it clearly because there is no invasion or something like that. Then that's the philosophy behind the way I try to contour. Although in this clinical case, for example, regarding the right parotid, I think I could have. I'm looking at it right now. I maybe could have corrected a little bit more because there's a fascia over there. So
Kind of pull off, kind of
yeah,
maybe pull off on these slices.
I'm just looking at it right now, and I'm thinking about it right now. But yeah, probably I could have, like cut it a little bit, especially the high dose level. Yeah, probably I could have done it tighter in that slide, in those slides. Yeah.
So so John, conceptually, once you move, so you do the GTV, do you then, how much reference do you then make to the PET for the CTV designation, if at all? Or is it kind of like, you've got once the GTV is on, then mentally it's 5, and then not enters the string?
Yeah, personally, for the CTV, let's say the microscopic disease, I rely on surgical series. I mean,
yeah.
The spread that has been described in surgical series, where they say about 90% or 95% of the microscopic spread is between 1 millimeter and 10 millimeters, for example. Then I try to apply that knowledge from the surgeons in order to apply it to our image. So that's why I carefully try to delineate the GTV, because everything is going to be then translated into the CTV. If you delineate a smaller or bigger GTV, then the 5+5 is going to be based on your GTV. So that's the idea. Yeah.
Oh, I'd like to hear what Moose does. Let me flip over to Moose. And
here's where I differ. So I'm purely a fascia plane guy to like an obsessive extent. So what I'll typically do is I'll actually draw my CTV2 first before I draw my CTV1. And so what I'll do is I'll do a centimeter on the GTV, okay? And that'll help me define where I'm thinking of, I have to go out from the primary onto the CTV2. But then I'm always thinking about fascial borders. So like the masticator space, you can see I'm not going into the masticator space at all. The parotid, I'm not touching at all. I'm not going onto the tongue here because there was no, it didn't go into the glossopalate sulcus. It just occupied that space, didn't extend down before it went up. You can kind of see I'm going into the muscle there because there's probably ECE in that node. But if I'm not convinced there's ECE in a node, I won't go in the muscle. So everything is really, really border defined. And I do not look at the PET again until the end when I have my PTV expansion on, and I'm just making sure I'm not missing anything. Like this is I'm just looking at the unfused PET with the PTV and making sure I've got all the growths in there.
It's kind of like a safety, it's kind of like a sanity check at the end.
Exactly. But you can see I took my centimeter expansion, and this is make my CTV2, and then I do a 5 millimeter expansion and combine that to my CTV2 as my CTV1. Does that make any sense?
Yeah.
So you can kind of see that pretty tight. If I'm concerned about masticator space involvement, I'll go in there, but I'm not really concerned in this sort of situation unless they have trismus or signs of it. And then I will include a lot of the masticator space, so I kind of use those boundaries very, very tightly. I'm kind of a purist based on those surgical boundaries.
Interesting. Yeah. Okay. So like a totally different conceptual approach from John. But so it's interesting. So just for illustration, I'll pull up the because I can see all side by side. But if we look at then there's Moose's CTV1, and then here's John's CTV1, right? I mean, I think you kind of see the volume, volumetric kind of effect as opposed to this kind of compartmental style.
And for me, the big thing is the tongue here, where like I don't really think there's much risk to the tongue, and I can spare a lot of oral cavity dose. Maybe that's crazy, maybe that's not, but
yeah, but still, I think even with that probably different approach, I think that the most important differences are at the top and at the bottom a little bit, base of tongue.
Yeah.
But the rest is, in general, I would say it's pretty much the same.
yeah, very similar.
You spare more a right parotid gland, more submandibular gland, and more base of tongue. But in general, I mean, I don't know the volume exactly, the measure in cube centimeters, but I guess it would be very, very different.
No, it doesn't seem radically different. So conceptually, we have a very templated kind of approach within the group. And so because of that, we have, something that's probably closer to what Moose does in terms of these constructs of anatomic compartments. So, our kind of mental process starts with parapharyngeal space coverage. And so what you'll see on almost all MD Anderson tonsil plans is that, the 66 or 70 gray volume for tonsils starts at this maxillary tuberosity and covers, and again, if I had not felt nervous about this posterior region on the RP node, this would be a little more constrained on the target volume. It's really, a 5 to 6 millimeter margin, but we tend to also edge for accounting for volume averaging in a way that's a little more aggressive. So you can see, here again, I don't really feel like the base, unlike Moose, I don't feel like the base of tongue is involved, but I put a 5 to 6 millimeter margin on that front edge, especially in a patient like this who doesn't have intraoral immobilization, right? So one of the key things is we typically, for almost all our patients, we use intraoral stents. In patients without stents, I'm a little more generous anteriorly. In patients with stents, the immobilization takes care of that, volume uncertainty, and so it makes it a little easier. You can see very much in agreement on this coverage on the node, but we're much more aggressive in coverage into the parotid fascia, and that's in some degree predicated on this slice. I did feel like there was this extracapsular spread on this posterior aspect. So to me, covering this region aggressively is imperative, and we have this kind of idiosyncratic manner of covering around the mandible to cover this kind of juncture if there's a node sitting right at the immediately posterior to the mandibular ramus, because this is an avenue of potential failure. So this is almost always covered with either elective, or in this case, if it's right up against it, we actually just, I covered it with the CTV1. So much less potential for parotid sparing than what you guys, I think, kind of indicated. You can also see in this, this lesion, once you've got this kind of, GP sulcus, even without the base of tongue involvement, essentially sacrificing the ipsi submandibular gland, right? So again, we're kind of like, once that submandibular gland is going to get radiated to a dose that's sufficient for unretrievable functionality, sparing this becomes, inconsequential, and it's easier to just make sure you've got aggressive dose coverage. So conceptually, on the node itself, you can see much more like, the high dose region really does cover, 5 to 6 millimeter expansion. But, we normally in planning, we would contour like this to show intent, but then once we do the PTV margination, would come off the air. So I don't, we just come off the air at the end of planning. We do an air column expansion. So we just segment the air column and then pull dose off at the planning stage. So even though this is in air at this juncture, it wouldn't be once you got to PTV. Although we'll talk about down here a little bit.
So I actually kind of disagree with a couple of things, but so one.
Yeah, go for it,
okay,
Moose. We feel, yeah.
I'm insulting my old mentor. So.
No, you're fine. You're fine. I won't tell David about your air column.
Yeah. So one is for the parotid. I've kind of with the philosophy, even if you end at that parotid edge, right? Your PTV is going to be 3 millimeters, right? You're not going to get follow-up from 70 to 50 and like any substantial less than a couple more millimeters.
Nope.
So I tend to kind of say that, even if I'm concerned about some EC around the parotid, I doubt there's going to be like massive amounts of infiltration into the gland itself. So that's where I might parotid spare a little bit more. From the air column standpoint, I'm actually, because I drew the lung window, I do all that stuff. I never crop my PTV out of air. I crop my CTV out of air, but my PTV goes into air because of swallowing. And then the interesting thing is at least with our intraoral mobilization, you guys are fancy and you guys have like dentists who can make these fancy devices for you. I actually feel a lot more comfortable with my setups for head and neck without all, if they don't have immobilization. Like I feel like everyone sets up really, really good when they don't have immobilization. It's sometimes when they have these somewhat odd tongue depressing stents and things like that they kind of move around. They don't slip their tongue in exactly the same way.
Yeah.
And so that's where I get the most nervous in terms of my.
Yeah, we have a big advantage because we have these oncologic dental guys, and when they make a stent, it's really good at immobilization, right? And we've been able to pull that off, because we have this ancillary support. I think, that's an internal process. I don't know how scalable that is, but for us, it does, this margination here and this margination on the vallecula is to some degree informed by the fact that I don't have a sense in a patient without immobilization how much their swallow motion is. Now that we're doing MR sims, we do a Cine scan and we look and see how much travel they have between swallows if they don't have a stent. But again, that's pretty niche.
Speaking to that point, I just wonder, what percent of the time is the disease going to move outside the field during that course of treatment? Probably pretty minimal. So I tend
pretty minimal.
So I tend to kind of throw that out the window, but if you have the ability, it's kind of cool. So,
well, we in my institution we use that kind of immobilizations specifically just for, I would say, mobile tumor tongues, where I want to spare the soft palate, for example, or then I try to depress the tongue, performing customized, individual customized immobilizations. And with daily CT, we still check every day. And I have, in my personal experience, is that it works, especially for tumors in the oral cavity. I don't use them, for example, this kind of tumors, even base of tongue, primary or pharyngeal tumors, we don't use any kind of immobilization devices.
And same with me. I think the only time I might is if I look at the sagittal view of the diagnostic CT and disease is extending up like near the palate, like for example, that. But some people have quite a bit of space between their palate and tongue.
Well, this is where again, I can tell you, our process, like for this patient, right? No base of tongue involvement, tonsil. You open that mouth up, you lateralize the tongue. You've now pushed that mucosa substantially to the other side of the tongue, and even more, you've moved that those maxilla away from any from low to moderate dose, right? Mm-hmm. So I think there's these kind of ancillary benefits, but I will say we're kind of checking it out. Eugene Coy is actually doing a randomized study. Because his prelim data shows you get monster dose savings to mucosa just by, in these basic tongue patients, opening the mouth and moving the maxillary, the maxillary mucosa and the hard palate mucosa out of the way. For the tonsils, you can get really like righteous. Like again, in this patient, if this isn't in the base of tongue, and you pull this tongue over, I mean, you can really score some big dose measurements. So I'm a convert, but it's easy for me because somebody else does the work. What about should we move to the John? Should we move to the CTV? Well, throw on the CTV2 and
Yeah, sure.
have you walk us through that?
What I do in general, I add another to create my CTV low dose, or CTV2 in this case. I add another 5 millimeter margin to my CTV1, and then I apply the same philosophy, correcting it by air and by bone, and by any other anatomical barrier that it's supposed to be strong for microscopic disease. And then that CTV2, I also add or incorporate the lymph node stations that are at risk of having microscopical disease, ipsilaterally and contralaterally, which means in this clinical case, I added to the ipsilateral lymph node area 1B, 2, 3, 4, and 5, and contralaterally, I skipped 1B in order to preserve the contralateral submandibular gland as much as I could. The cranial limit of the level 2, I did a little bit, I would say, I cut it a little bit compared to the contralateral one, and I tried to skip also the level 5th contralaterally.
Yeah, so I'm kind of curious, John, as you were kind of describing that, the coverage. Do you have a set juncture where you begin coverage of the elective neck? That is to say, is there a certain anatomic landmark that you use where you say, you begin coverage in that kind of high level 2, level 5 juncture? What's your kind of starting point superiorly for a node?
Superiorly is if there is, for example, for the contralateral neck, and I would say in the left side, if it's an N0 neck, I use the second vertebra as, let's say, as a surrogate marker in order to stop or to start, if you want to, the level 2. If there is gross disease in level 2, then the prophylactic cranial limit, I go a little bit farther up due to probably retrograde lymph node affection cranially. So that's why probably the limits in the left and the right side regarding level 2 are a little bit different.
So let me ask, I noticed you don't do RP node coverage, though you did cover across the soft palate. What are the kind of indicators to you where you would throw on RP coverage in addition to that level 2 coverage?
Okay. In general,
oropharynx, yeah.
Regarding, it's not published data, but let's say our internal data regarding the affection of retropharyngeal lymph nodes, I do cover them when I have posterior wall tumors, and I do not doubt in those situations. Or if I have, for example, in that ipsilateral side, a tumor that could drain, that's, for example, this one, a little bit, I cover the caudal retropharyngeal nodes. But if it is an N0 contralateral, I try to spare specifically the retropharyngeal area in order to preserve a little bit more the pharyngeal constrictor, especially the superior pharyngeal constrictor. And that's our policy in that sense. Yeah.
Moose, other comments, questions for John?
Not in particular. I'm surprised he didn't cover the higher retrostyloid nodes per se in this situation with the involved low neck. If you'll see my volume, I cover those nodes pretty high up.
Yeah, so right here in this juncture, as you're moving down, you would start that a little more. Yeah.
So my CTV2 is where you see the purest in me come out. So you can see
Whoa, yeah. So we'll start at the top, but narrate for me. I'm gonna come back to you. I see some stuff I'm fascinated by.
So here I am. I'm covering what is really the absolute superior extent of the parapharyngeal space, the best I can see the fat there. Going down further, you can see I'm extending behind the RMT just because of kind of that potential spread along the tonsil that way. You can see my nodes go down. I did cover the digastric on the right normal because I'm concerned about the lymph node just inferior to it, maybe involving it.
Yeah.
If I wasn't concerned about digastric involving that node, I would have kind of pulled my medial muscle, my CTV in to spare the parotid a little bit better. I'm not going into the tongue, because I don't think that there's any involvement there. I'm coming down to the platysma, going down level 1, and then no basic tongue involvement, so I stayed off the vallecula, and the larynx there, and then I'm doing level 2 to 4 on the left, again sparing the submandibular. On the right, there's not really medial submandibular nodes, so as a purist, you could theoretically try to spare the right submandibular. It's very, very, very hard to do unless your anatomy is like really, really unfavorable. But I feel like Dave is like fascinated.
Yeah, I am. So I guess I'm very interested. You got really what we would again collectively we would consider this level 5 coverage aggressive.
Yeah.
And this level 3 coverage comparatively sparse, right? Which is interesting, right?
Really?
Yeah, because I mean, you got a node right here. We would say, well, you got a node here in 3, and then boom, now you're, you'll see we're a lot more aggressive in this anterior level 3 at a cost of admittedly some larynx dose, right?
Yeah.
I'm also intrigued, like you really like the fascial, you really respect the fascia of the submandibular and parotid in a way that I obviously don't.
Yeah. I mean, I think I do it case by case.
Yeah.
I think I really do it case by case, but I think, for me, it's like these little wins wherever you can win that you can spare a little dose, you get a little bit farther from the oral cavity, that sort of thing. So my volumes are like my residents. I don't think my volumes are massive, and I think my volumes are like smartly massive. So I'd like to think.
So I gotta tell you, this one here, that RMT, where to pull that RMT coverage on glossotonsillar, glossopharyngeal sulcus cases is always, like the bane of my existence, right? Like I feel like I fight more over this wedge of real estate, and the artifact doesn't help you, right?
Yeah.
But I mean, I always feel like this is always a battleground when we're doing multi-D.
Yeah.
I feel like this soft palate coverage is always like, again, the bane of my existence.
For me, with this palette, I did a centimeter on the GTV, and that's the palette I'm covering. So if you look at that,
interesting. Yeah.
So you can see I expanded my GTV a centimeter, and you can see I'm staying off the rest of the palette there. Yeah. And that's how I approach it, very puristically. So everything is like very systematic and
yeah. Now, if you look at John's CTV2, CTV1 pretty consistent, right? That retrostyloid coverage, big difference. I mean, retrostyloid coverage, RMT coverage here, and then as we talked about that level 5, the fact that we're not as aggressive about contra level 5, and I don't think we're as aggressive. Stephen Frank, though, is constantly getting on to me. He's always thinks I'm too skimpy on posterior level 5. So this is also an area of magnificent debate on a regular basis.
It's a low morbidity area for me, and it's like, why bother, like being super cute about it. I think level 5 for me, if it's a base of tongue, I typically don't cover level 5, but for tonsils, if 2 is involved, I will.
Well, and I'm curious here. We'll talk about this in a bit, but this vallecular this molecular transition zone is also one that leaves me, you know, a little bit, you know, routinely kind of in doubt about where to be. So I'll show you mine, and we'll kind of go from there. So, you know, the way I would have done this. So I chose to kind of illustrate this. So this is what I felt I would have done, which was treat this like soft palate involvement, you know, directly. So, you know, we kind of make this go, no go decision that if it crosses over more than 1/2 of the soft palate, you buy full soft palate elective coverage. And we don't tend to break up our volumes. So again, you'll see we have this kind of continuous coverage of the entirety of the soft palate as you're coming down. So a little more aggressive until the soft palate breaks. What's interesting is, you know, again, even here, you know, even though I believe that there's an RP node, my retrostyloid coverage isn't as aggressive as Moose's is, which I think is interesting because, you know, from a parotid sparing perspective, I'm sparing the top of the parotid, and Moose is sparing more of the parotid lower down, which I think is kind of intriguing. For soft palate, that buys us a little bit of additional RP contra coverage, again, once you make that commit. So once you make the commit to soft palate coverage, we have internal data that suggests that soft palate coverage over the medial, into the medial half, comes with some marginally increased risk of RP nodes. So we're kind of concerned about that. You can see, you know, like Moose, I'm covering level 5, like John, I'm covering, but I'm covering less. We don't push as aggressively to cover even the posterior aspect of level 2 on the contra, which you can kind of see there. We cover elective all the way out to the platysma, right? So again, more kind of compartmental than what looks like. And again, you can see, like we're talking about with Moose, a little bit more anterior coverage in that level 1B, level 3 interface junction that then kind of, you know, carries down for this, you know, as evidence of that node. You know, I feel like again, you know, this posterior border is an area we haggle with a lot, but conceptually, I feel like I'm, you know, I wouldn't disagree with what either of you guys are done. The other thing,
inferior border is pretty high.
Yeah, inferior border is pretty high here. Now, the real question is what to do about this guy, right? So if this is true vallecula, we kind of convert to something that looks more like this, right? So if John had said, hey, I saw vallecular involvement on exam and not kind of foot of tonsil involvement, then we also convert to buy this obligatory preepiglottic fat space coverage. So once you've got physical exam on vallecula, boom, now, you know, PEFS coverage is gonna burn you some larynx dose, right?
How low do you go?
Typically we cover into I use the MR. So you cover until you see the fat space, and then once you see the larynx, once you see the laryngeal cartilage, you stop, right? A little bit of, and again, you'll get a PTV drop off, but it makes your larynx dose a pain in the butt, and it buys these patients significantly higher risk of post therapy aryepiglottic edema. And so, you know, it's kind of these things where, you know, this turns a lot on. I felt like this was foot of tonsil with. I felt like this was more like a foot of tonsil with, than vallecula BOT. But if it had been, if John had said, hey, I saw the vallecula, now you're buying this stuff down here too, which really makes toxicity awful, right? So for us, that difference between vallecular involvement, you know, if you've got vallecula and soft palate, I'm hosed in terms of a lot of the sparing. But, you know, my impression was really more that this was soft palate involvement, and that allows me to come off this and avoid all of this laryngeal laryngeal preepiglottic fat space dose. But again, that's that thing where that physical exam really comes, like you're saying, like John was saying earlier, you feel a nubbin on the, next to the uvula, you feel a nubbin down on that vallecula. Now you're in a whole world of hurt on the same imaging.
So that's funny. I'm also purist there. I just do a centimeter on my GTV, like where the base of tongue is going into the preepiglottic fat. So
really, even for follicular stuff?
Yeah.
Fascinating.
Yeah. And that's my
Yeah.
CTV low. Yeah. And so that's,
I mean,
yeah.
we kind of sweat vallecula because there's not even a fascial layer there, right?
Yeah.
So, there's really comparatively limited protection of that preepiglottic fat space. And so I think we think about that, if you see direct involvement, we're now you've committed to a comparatively more toxic CTV2.
Yeah.
So now question of the day, what's your dose for CTV? What's your dose for CTV1 and fractionation? What's your dose and fractionation for CTV2?
John?
Well, okay, I'll go first. Okay. In general, we perform, I would say, for the vast majority of the patients, simultaneous integrated boost technique, which means that we do 33 fractions of 2.12, reaching 70 gray for the GTV, let's say CTV1, sorry. And then I try to give the dose to the CTV2, which is in general like 56, something like that, in 33 fractions, which means 1.8, 1.7, depending on the clinical case, to the low dose. If we perform in some cases 35 fractions, that means 2 gray per fraction, 35 fractions to the CTV1, and to the CTV2 elective 54, again, something like that at 1.8, 1.7, depending on the clinical case. But that's pretty much it. We don't do, let's say, 2 different phases, one till 50 and another one till 70. We do simultaneous integrated boost with that kind of fractionation for almost all of our patients.
So we do, I do 70 to the CTV1, and for P16 positive, I'll do like 5250 to the 35 fractions. For P16 negative, I'll do 54 to 56, probably 56 in that case. And that's I'm a 2-dose level guy all the way for head and neck, except from the post-op setting where I have a high risk volume.
Interesting. Yeah. So two dose levels, and go for it. Do you guys? Well, yeah. So I'll say we routinely. So I would normally treat this to 69.96 in 33 fractions to the CTV1. I would probably paint in a 66 for that RP node, but 69.96 to the primary in the big boy in level 2. The dose to the CTV2 would be 54 or 56. 54 for HPV positive, 56 for HPV negative. Again, dosimetrically probably insignificant values, but some kind of idiosyncratic kind of thought process. Do you guys adapt?
I do not, except for weight loss.
John?
Yeah, we do. What we are doing now, indeed. We have, let's say, we have reviewed like lately in about 110 patients, something like that, prospectively, with daily COMBIM CT, in order to try to detect what kind of patients in our institution tend to need adaptive radiation therapy, because we wanted to avoid, like they call you to the machine and you see a huge difference and you now need to run. So what we do in general is daily COMBIM CT in patients where we start seeing some differences, especially in patients that do lose 5% of weight loss, we then calculate in the last COMBIM CT the dose and the dosimetry to see if there's a tendency really to, if it's going to matter. I mean, if it's going to be a very big difference, and if it's so, we replan the patient, especially the patients N3 at the neck, patients with more than 5% weight loss, and specifically patients undergoing concomitant chemo. We have detected as an independent prognosis factor in our institution to need an adaptive radiation therapy. I'm not talking about meeting specific constraints to the parotid or like being super specific with some specific organs at risk, rather than a patient where you feel that the IGRT is no more going to make the patient fit in the anatomy. And then we do adaptive radiation therapy in those cases. I think I explained myself properly.
Yeah. No, that's, yeah. So it sounds like, you verification, assessment, and then a decision, a go, no go decision on,
Exactly.
on adapt. Yeah. And then,
Exactly.
and that's CT sim with contrast, just like baseline, or is that made off the cone beam?
Yeah, if we readapt, we perform new mask, new CT, and then we perform the formable fusion of the original, let's say, contours, and we check structure by structure, and to see if the algorithm did the work well or how bad it was, and trying to make it sense again. And when the replan is set, the patient continues with the new plan.
Yep.
I used to adapt a lot more. And then I started just CTing people and recalculating the ISO on their weight loss scan.
Yeah.
And just seeing how much of a difference it made dosimetrically. And it really didn't. And so I find myself rarely adapting unless they don't fit in the mask to the point their setup is like really bad. And usually by that point, they've got like 3 fractions left. So you I kind of just make sure that the IGRT's on and just cross my fingers, I guess, a little bit,
I mean, I guess we kind of split the difference. We, our standard practice is to get we call it a verification sim week 3. So we get CT MRI for planning, CT MRI week 3. They do auto segmentation and deformable registration, the target volumes. We superimpose the current dose. Then there's a go, no go, deciding whether we adapt or not based on that. So it sounds like, kind of a intermediary between.
How much weight loss are you seeing at week 3 though?
It's mostly, I mean, well, there's 2 reasons, right? One is a lot of our patients, we do protons, right? So it's more planned fragility as a function of even small amounts of weight loss.
Yeah.
And the other is we adapt targets. If you see like this node or this, primary shrink substantially, we'll adapt target for, not aggressively, but we'll make adaptations if it's, like here, a lot of times these tonsillar cases, as they shrink, they'll pull away from the posterior pharyngeal wall and you can get a little bit more sparing of either the parotid or the pharyngeal constrictors. We don't adapt GTV off protocol. We have a protocol for MR adaptation, but we don't adapt, the full GTV in most cases. It's really just if it's responsive, but it's kind of opportunistic. And then I assume you guys, again, in a case like this, cone beam CT daily for setup in most cases. Yeah.
We do daily cone beam CT, absolutely.
Yeah.
Indeed. I don't know what your experience is about that, because many published articles, talk about adaptive radiotherapy in the 4th or even 5th week. But I do see sometimes even in the second or third week, already big changes, especially in patients with really enlarged lymph nodes that respond early to treatment. I don't know. You
Well,
find something like that?
you're preaching to the choir here, because we have a study where we're really enthused about the idea of high frequency MR adaptation, right? We're doing the studies to investigate it. I personally have seen, very if you look at the data from Stephen Frank's some of Stephen Frank's early work, we've seen that MR shows that half of our chemo RT patients have no visible disease in the primary. Okay, but what to do with that? So you see a response, sure, but until we have study data, I don't think that any of us really know how aggressive, and I think that data is going to be coming out, and I think, Dave Brazell has a really exciting study where they do a PET scan at 20 gray and then volume adapt and dose adapt. So I think those studies are coming down the line, but there are these patients who are, I feel like, and Moose and I have talked about this before, there's a subset of patients that are really early responders. And, could we adapt on those cases? Problem is, you don't know who they are till they.
Yeah, absolutely. Yeah.
Yeah, I think Nancy Lee's approach with F-MISO is kind of a similar construct or thought process, right? So I mean, there's some cool stuff coming down the pike, but I don't know how. I wouldn't tell anybody they should do it.
Yeah, for sure. Yeah.
You know what I mean?
For sure.
Yeah. Well, I mean, other comments or questions? I think we may have beat this horse to death. I gotta say, I really enjoyed this. I'm with John. I feel like we have some distinct approaches, and I think there's, other than the fact that I apparently see RP node danger where you guys do not. But the good news is Moose would have covered it anyway in his aggressive retrostyloid coverage. And John edged up on it pretty close. So I don't know that it would have made a massive dosimetric difference, but very intriguing to see the differences between the panel.
Yeah, I mean, I really think looking at the dosimetry of the plans would be really interesting, and just how to, I'm a planning dork, so I know how to plan my own cases. So I would be curious to see how we would. Just how they would look,
Yeah, how much do you lose in the wash anyway? What PTV margin? What PTV margin do you guys use?
3.
Three,
Throwing it
John?
up.
Yeah, we calculated it some years ago, and we do give 3 millimeters in the x-axis and sometimes 4 millimeters craniocaudally because we saw a slightly more difference.
Yeah.
But I would say in general 3, and if you have doubts, then 1 additional millimeter in the cranial and caudal limit sometimes.
That's interesting. I cheat on the caudal limit, especially with like my basic skull cases, like 2 millimeters I'll do if I'm heading to the brain.
It's funny. We had some work many years ago that showed, just like you're saying, John, that the axial the axial alignment, because people are aligning axially, the systematic errors are in the supintension with CBCT. If you look at the X-ray, kilovoltage X-ray, you get much tighter sup-inf setup, but it's the axial displacement that's a little more pronounced. So we're right with you guys. For cone beam CT, we use for cone beam CT we're using 3 millimeters for 3 millimeters for the photon cases. For the MR Linac, we're using 2 to 2.5. So just because we feel like we have a little bit tighter soft tissue constraints available there in terms of visualization, but very similar ballpark.
Yeah.
Cool.
Well, I just had one let's say final comment from my side is that even though we've talking about some slightly different approaches, etc., what I in general saw or detected is that you both, or even me in my case, we tend to do it pretty homogeneously in our sense every day. So I think that's the point, is that if you are consistent every day, you're going to be able to see your results finally, and then from that you obtain the conclusions if you're doing wrong or not, or you can improve, or there is room for improvement, whatever. So Muse was super systematic, with the fashion, anatomical spaces. You also, Dave, make your comments regarding soft palate invasion, the molecular stuff. So there's a very specific action in each moment. So I think that's the in my case is more than the homogeneity regarding 5+5 and then an anatomical correction, but still it's kind of every day the same. So I think that's, in my opinion, a very important point when controlling these patients, that you be systematic in the way you approach each patient. So that would be.
John, as you're saying that, it reminded me the late great David Hussey used to say occasionally to us, it's better to be systematically wrong, because then you can make corrections. If you're randomly wrong, you're always going to be guessing.
Yes,
and I always appreciate that jumped out at me when you were saying that.
And I mean, I think if you have a thought process, it's really important, because I think what, at least with residents, what I see is they kind of, contour stuff randomly. They're kind of going into these sort of areas, and it's not consistent. And I always say, come back, where's this? Why are you going here? And ask yourselves these questions over and over again. And then they ultimately, by the end of the rotation time, then they can kind of approach a case and use it, whether it's this relatively common basic tongue case or tonsil case, or apply that same principle to an advanced, space, tumor that's involving the entire pterygoid. And, so if you have an approach and a thought process that's really flexible, rather than just saying, I'm covering level 2, like they're looking at the atlas and covering level 2 and looking at the atlas. That's the flexibility of it all.
Absolutely.
Yeah, definitely.